I want to thank Sharon for that wonderful introduction. She's just such a great colleague. And I also want to thank all of you for being here today. I know you have lots of things going on, and I just really welcome the time with you. I'll just share a few thoughts. You know, it's not often that someone calls you and says you can talk about whatever you want to talk about. And so I'm like, well, you know, you think that's easy. It's almost easier to have someone tell you what you want to talk about. And so I thought, what should I talk about? So I called Robin Begley, who's the CEO of AONL and a good friend. And I said to her, hey, what do you think? And she said, well, people want to know a little bit about you and what drives and what has accelerated your career, what are some of the key points. But it was also an opportunity to talk about an issue that I've been involved in now for a number of years, which is workplace violence reduction. So what do we need to do differently in addition to the efforts that we currently have now? And I'm telling you this because I'm setting the stage, because I will have a less than graceful transition from one topic to the other. And I'll let you know when that is. So anyway. All right. So you'll see we have two different learning outcomes. They're up there. One is about identify potential career accelerators, and the other is discuss the importance of a holistic approach to addressing workplace violence in healthcare. Just some of the things I've been learning lately. So you can ignore the picture of Pee Wee first, but when I went out to Milwaukee, it was referred to by my family as Mary Beth's Great Adventure, and I love her Big Adventure, and I always enjoyed that Pee Wee Herman movie. But that really aligns with one of the accelerators, and that's calculated risk. But first, I want to talk about engagement in professional organizations, and I mentioned that briefly this morning. But it was so interesting when I sat down to really think about this, how connected everything was when you go back to look at things. So early on, I was involved in actually SEPA, Southeastern Pennsylvania American Association of Critical Care Nurses. We put on a big conference, and I got comfortable with speaking in public and running meetings. Anybody here from SEPA or Southeastern Pennsylvania? Liz? Yeah. Just a few. But then when I moved into leadership, I got involved in what's called SPONL, the Southeastern Pennsylvania Organization for Nurse Leaders. That led to PONL, the Pennsylvania Organization for Nurse Leaders, and that then led to AONL, the American, at the time it was AONE, to be honest, and I was involved in that name change. And that led to a number of opportunities that I alluded to this morning. Most importantly, a board, a board role with the American Hospital Association, and then being able to be on the executive committee of AHA, which was a great experience. And I got to know CEOs in that area. So I think that's one thing, is that relationships and how you connect with people really do matter. And so two of the CEOs said, hey, you know, we would like a nurse on our board. Would you be interested in interviewing for that? And I did, and it's been a tremendous experience. But one of my mentors for many years is Joanne Dish, and I know Rhonda knows Joanne. I'm sure there's a bunch of folks here that know Joanne. And she shared with me a number of interesting observations about nurses serving on boards, and I want to share a few of those with you that she had talked about. One is that people will often now reach out for a nurse to be on the board in healthcare, which is wonderful. And that's partly a result of the work that the Nurses on Boards Council has done. They've done a fabulous job. But I think the other thing that she said is that people sometimes are surprised by what they get, and not always pleasantly surprised. Hopefully they're surprised pleasantly, but not always, because we bring a great deal to the table. And that's the second thing, that the boards and organizations really get a lot from nurses on their boards. When you think about it, so yes, every time I always say that nursing word is mentioned, someone will turn around and look at you. But there are many other things. We bring the nursing voice, we bring human caring lens, which is what we're all about, but we also manage giant budgets. So we bring a tremendous amount of financial expertise that many others do not. 42,000 nurses in Advocate Health. We are experts in human resources as well. Maybe not all the comp stuff, but managing people. We are all involved in facilities management and safety. We bring that to the table, strategic planning. I could go on. So when you get a nurse on your board, you're getting a lot. So Joanne's advice to me was, don't sell yourself short. And don't be afraid to comment on things that aren't just nursing. Bring your voice to all the issues that are there to bear, not just to talk, but you have much more to bring in addition to your great nursing background. So that was very impactful for me. Opportunities that I've had have also been fabulous. And I'm hoping that some of these career accelerators for those in the early or mid stage of your career are things that you'll be thinking about. For those of us at the other end, you might just smile and say, that happened to me too. But one thing that really impacted me, an opportunity, was being a Robert Wood Johnson Executive Nurse Fellow. Do we have anybody in the room that participated in that program? It's no longer in existence, which is really, it's hard, but they have other programs which are interprofessional, and there are many other opportunities for fellowships and things that really strengthen your role as a leader. And so what happened there was, I just broadened my horizons. I was in a cohort, it was a 3-year program, and they asked a question, and they asked it the entire time. And what they said was, are you in the role that you should be to influence healthcare? And at that time, the answer to me was probably not. And it was also a time when I could make a change, because I do think, as nurses, we've got to balance our family needs and our life needs. And at this stage, my children were older, and my parents had passed away, so I had a little more flexibility in terms of movement. And I'm in this cohort, and I'm talking to people, particularly in academia, and they're like, I'm moving for my job. And I'm like, you're moving for your job? I never thought of such a thing. I grew up in Philadelphia, suburban Philadelphia. That's where I lived my whole life. My whole I have 41st cousins. They all live there. I'm one of 6. They all live there. And you know, I thought, well, maybe I could move for my job. My family thought I was out of my mind. They didn't know where Milwaukee was. They just said it's nothing I would ever have thought of doing. But my one sister and my husband both said to me, you know what, you've made a lot of decisions based on what we needed. Why don't you do something that really speaks to what you think you need to do? And so with that, I did do that. So that's the calculated risk. So that was my big adventure, that I did go and I moved for a job. But that one change opened up a lot of possibilities. It was difficult first year because I was commuting. Anybody commuting for their jobs in here? There's a lot of us out there that are going back and forth between home and work. So anyway, a few years later, we merged with Advocate Health, and I was at a Robert Wood Johnson reunion. And I said, you know, maybe it's time. Maybe I should just go back home. And they got around me and they said, are you kidding me? You need to apply for this job. And they were, you know, kind of beating me up a little bit. And that peer support really meant a great deal. So lastly, and this is something that I think is also very important, and this is just the career accelerators, is to remember that our leadership skills are transferable to a lot of other things that we can do. And I think we sometimes forget that. You know, one great example, we participate in a fellowship program as part of an external program. And I've had 3 nurses go through that I sponsored who are now presidents of hospitals. And people will come up to me and say, aren't you upset that these nurses are now CEOs or COOs or hospital presidents? And I say, I'm delighted that they are in those roles. How wonderful is it to have nurses in an expanded role? This is fabulous news. So really recognizing that the leadership skills are transferable. And then I learned that when someone asked me to become the director of emergency department, I had been working part-time as a supervisor with 3 young children with no ER experience. And this person saw something in me in a very troubled ER and asked if I would take that over, and I did. And that, my friends, is my less than graceful transition to workplace violence. So as an I know. So as an ED director, I had quite a bit of workplace violence that I saw, believe it or not. And unfortunately, I think we can all tell stories. We can tell horrific stories of things that have happened that are just so tragic about our coworkers being exposed to violence or being victims of violence. And I'm looking at Renee right now. I'm not even going to talk about bullying and incivility. I'm really talking about just a change that we need to make with patients and families, at least from what I can see. As a new nurse, I think looking back, I don't think I remember workplace violence. I think, looking back, maybe a couple things that happened, but it was a long time ago, and it just didn't, maybe I don't remember, but it just didn't hit me at the time that it was violence. We didn't talk about it in that way. As a supervisor and an ED director, I would be called to respond to different things. So that really did, I would begin to see it. And in the ED, I not only saw how this affected our nurses and our healthcare teams, but I saw how it affected the way they interacted with patients. And that was something, I didn't pay as much attention to that then, but I thought about it. We had a triage room. They have done new facilities like 5 times since this time frame, but we had a triage room that had a door, and then the nurse sat with her back to the wall, and the patient would come in, and there was no place for the nurse to go if there was a problem. And you could see the fear that happened. We were in an inner city emergency room, lots of things going on, and you could just say, nobody wanted to be in triage because you could be bombarded. A simple thing like putting an exit door in the back helped with that, and helped, I think, change the relationship that I saw as people were triaging patients. So I began later in senior leadership roles working with safety and security. And I remember one time specifically, and it was at Aurora, I was sitting in a room we had 15 hospitals at the time, all the chief nurses, and I recounted this really difficult situation that had happened at one of our sites. And as I started to tell that, one chief nurse goes, "Oh yeah, we had somebody that was just pushed up against the wall the other day, and oh, we had somebody that," and I was just like, oh my gosh, we had all of this workplace violence happening. Now I'm talking about 10 years ago. And we didn't put it all together. Nobody really knew what was happening in all of those different sites. Now, I'm happy to say that has changed dramatically since then, but we didn't have our eyes on the really whole picture of what was happening. Now, if you fast forward to today, or let me go back 10 years ago. About 10 years ago, maybe a little bit longer, AONL collaborated with the Emergency Nurses Association and did a white paper on mitigating workplace violence. And the thing that was so cool about that was that at the time, people in healthcare wouldn't even mention violence and hospitals or healthcare in the same sentence. They just said, this is bad for business, and the problem was there. This is not a new problem, as you know, that we're dealing with. Maybe accelerated, but not a new problem. But thankfully, that has changed. What has not changed is people believing that it's a top priority. So AONL does a survey, and they've done it, I think it's for the last 5 years, 4 or 5 years, and they ask top priorities for managers. And one of the things that keeps coming up, what do you think the first one is? Staffing. Somebody asked me a question the other day, or tonight I have to do something, and they said, you have to say what the challenges are, and you can't say workforce. I said, that encompasses like 8 things. So anyway, it's workforce, it's staffing, and then it's workplace violence. And the thing that's interesting is it increased year over year over year as being identified as the top priority. So it's a huge issue for nursing and nurse managers. So we're making some progress. And again, this is not to go through all the things that you need, that's another talk. But we're making progress, and I did list here a few things that I think are fundamental. So as we're responding, protecting nurses and other team members, these are the things that we're sort of foundational that you have to have in place, whether it's, and I didn't even list threat management and working with the community, but things like behavioral response teams and mobile duress alarms and EHR identification, de-escalation. You can see the list yourself. These are things that we need to do, but we really haven't made tremendous progress. Have people in the room seen a decrease in workplace violence, even with a number of the things we've done at your sites? Yeah, it's really something that I've begun to think about that we're doing, and people are responding. People, I think in healthcare, people really care about our workforce and want to protect them. We're not making a difference right now. So I've begun to think, what's missing? And Sharon Quinlan's here in the audience, and I work with Sharon. And I remember one time that you were in a DE&I meeting, and Sharon does a lot of work with shared governance. So she came in and was saying, shared governance, everyone is so upset, we've got to do more for workplace violence. And a couple of the folks that were in this DE&I group said, well, that's good. I think that's important, but I've been in situations where I feel a little bit disrespected when I'm in hospitals. Is that, if I respond or say something, does that mean I'm being violent? Does that mean that I did something wrong? Or is that the responsibility? So it just started to raise some interesting questions in my mind. And I think what we're missing are strategies that go a little farther downstream. We're missing the patient-centered approach is what we're missing. And I say that because I'll say the royal way, because I include myself in that. I have been really very focused on what do we need to do to protect our teams. And I need to continue to do that. We all need to continue to do that. I haven't been as focused on, okay, so we have a no tolerance policy. What does that mean? And who decides when it gets to that level? Is it if somebody yells at you? So it's confusing for people. And I don't think we've really thought about it. Another example is, trying to predict a little bit of what's happening. At one of our sites, we had a situation, and this was again a couple years ago, but where a gentleman who had substance abuse issue, a couple of pretty significant issues, and some behavioral issues. He had fallen off a roof and he was having spine surgery, and it was on a weekend. And I got a call that he, acted out and was running up and down the hallways, and patients were shutting their doors, saying to the nurse, "Let him take me because you're young." And it was really scary for everyone. I know, can you imagine? We think that this it affects everybody, but the point is, were we surprised that this happened? And could we have identified early on and had a plan of care for a patient that we thought, even just coming out of anesthesia is a risk factor. So there's some of the things I'm worried about. And this is a little bit controversial, that I am going to say, because I've seen it in some situations, that in some instances, and again, please believe me, I'm all about protecting and not blaming our teams. They just don't always have the tools, but in some instances, we have created an us versus them approach. And that is not what we're about. We are about creating places of hope and healing. And I'd love to tell you that I have, the answer, but you will probably realize I do not. So the call to action is, to me, is have the fundamentals in place, but also implement strategies that seek to understand where the patient is and what might be causing some behavior. Now, unfortunately, it's not unfortunate that I have a colleague, but unfortunately, a colleague of mine said to me, Mary Beth, there's no easy button for this. There's no, if you see this, then you must do this, because there are so many different factors that impact a person and a patient's response. So again, this is challenging. This is a situation that requires a lot of thought and a lot of skill. But there are things that we can do to have a more comprehensive patient-centered approach. I listed a few here, and I'll go through them, and then again, this is not an exhaustive list. But first of all, the de-escalation training that we do, it's got to be meaningful. We can do some online things, but unless people get a chance to really practice in a simulation and see what's going on and really try things out, it doesn't always help them when they're in a tough bind. We can reduce stressors. So, all right, so I'll admit this. I was on the phone the other day. I wanted to change something that was happening at a certain time because of the girls' basketball game. And I was on a tour, and I forgot that we had a time zone change in New Orleans. So I'm on the phone. I'm going through all the automated things. Well, I wasn't at my best when I got to a person, and I'm just going to say that. I was kind of like, well, if you're so inflexible that you can't, and I thought, that person could have just said, lady, won't. But they had customer service training, and they were able to talk to me and to say, here's the situation, here's what we can do, here's what we can't do. And I immediately, I wasn't out of control, but I immediately calmed down a little bit. And I think we are not putting enough focus on that with our frontline teams, on just plain old customer service. And if you have somebody, we'll talk about the social determinants of health, you have somebody that maybe has had to take a bus and walk to get to wherever they're getting for care, or they have an issue at home, or they have a problem, or they've tried to get an appointment, and then you have someone that kind of turns them off, that's just the drop. That's that broke the camel's back. I mean, that's what it is. And so can we look at some of the stressful places in our system and try to reduce those, whether it's customer service training or whether it's waits in the ED, really focusing on that throughput, because that's another area where you start to see people really start to come up. So I do think that. Identifying the social determinants of health. Now we're starting to screen, which is fantastic. But we need to have some folks working with us that can help with that. Early detection is the other thing. Are people using, in your ERs, in your units, are you using assessment tools? So STAMP is one that's really just focusing on I won't go through the acronym, certain behaviors, staring, the tone of voice, et cetera. And then you can begin then to say, okay, what's the plan here? We have potentially a problem before someone is really escalating. DASA is another one that you'll see used many times, and these are predictors that are really evidence-based predictors. Some of the ones that have been out there in the past have been based solely on behavioral health patients. And as a person that has a brother with severe or significant, who has been living with mental illness, I'm very sensitive about the fact that we cannot paint all our behavioral health patients with this broad brush of they're the violent folks, because we know that's not true. Matching the behavior to the response. And this was something, again, my friend I have a friend from the VA. They just do a fabulous job. They're able to do the interdisciplinary care planning because they see the same patients all the time. And so they have a program. When they have an incident, that whole team comes together and they look for their physical causes or what exactly is happening, and they make a very concerted decision before they even identify someone as having potential for violence again. So that plan, and they develop a care plan. And I think, again, we can learn a lot from that. But what my friend that worked in this program said to me, she said, sometimes the patient's here and we're here. So, and I think that's a very important piece, and that's helping our folks say, what's the behavior and what should the response be? Because what she said to me is, if the patient's here and you're here, you can be assured that patient and family is going to come right up and match where you're at, and then you're going to have a very volatile situation. So very much focusing on matching the response to the behavior. And then I would say reviewing to learn, not to blame. Because what I don't want you to leave here with today is that I'm saying it's the nurse's fault, it's the registration person's fault. I'm not saying that. I'm saying we haven't been giving people the tools and the right support to be able to do this. And we have not introduced the patient as much to this national discussion that we're having on mitigating workplace violence. And I think that that's really important. So there are just a few thoughts that I have on that. I think the key takeaways for me are that we have to begin to have a patient-centered approach combined with all of the things that we're doing to protect patients and families. Because what we don't want to do is wrap ourselves in a bubble and then let a patient come in. We want to have a place of hope and healing, and that takes this combination approach, which has not been, as I mentioned, part of the national dialogue. So what I would say is that zero tolerance may not be possible. It doesn't mean we won't continue to implement programs to protect, but we have to focus on patients and families and meet them where they're at if we hope to make an impact on this very long-standing, pervasive issue of workplace violence. We owe it to all who work in healthcare, and we owe it to all people who seek and need healthcare. And so for today, that's it for me. I just want to say thank you for letting me get on my soapbox about this. As you can tell, I feel strongly, but I think it's because I feel like I missed it a little bit, in my earlier years. And I think we can really make a difference if, as nurse leaders, we bring it to the national attention and we go back to our places of work and say, what can we be doing differently?